Good afternoon, and welcome to this webinar. My name is Daniel Malik Chala. I work for AfHEA, African Health Economics and Policy Association. Why am I hearing my voice?
Hear you, Daniel.
Okay, thanks so much. Today we are going to speak about sexual and reproductive health and rights, especially in the context of West and Central Africa. But before we start, some few housekeeping rules. I want to say that this webinar is available in both French and English translation. There's simultaneous translation going on. If you're a Francophone person, you can switch to the French channel by clicking the globe sign at the bottom of your browse menu, so that you'll be able to access the interpretation. If you are English, you can also switch to the English menu, and then you'll be able to access the interpretation. So this is actually a bilingual webinar. Before we start, I would like to say some few words about safeguarding. This work actually, as this webinar is part of a bigger project we are undertaking. West and Central Africa Region Health Policy and Research Organization, AfHEA has been selected by IDRC, the International Development Research Center, the Global Affairs Canada, and the Canadian Institute of Research, and to undertake this work called the Health Policy and Research Organization in West and Central Africa. And this work that we are about to present to you is basically a scoping review that we did into sexual and reproductive health in West and Central Africa, the extent of the gaps in this area, and what actually needs to be highlighted, for more efforts in terms of interventions to address these, challenges, especially with regards to sexual and reproductive health in Africa. And so I would like to say that before we start this webinar, just say some few things about safeguarding. AfHEA is a believer of openness, and so we have some safeguarding policy, especially with respect to this project. And our safeguarding officer is Dr. Fadima Yaya Boku. Dr. Fadima Yaya Boku is actually our safeguarding officer with respect to this project, the focal person. So if anybody has any issue in terms of anything regarding this project, please feel free to contact our safeguarding officer. I was going to project a slide about that. So AfHEA, as I said, is committed to creating a safe, respectful, and inclusive environment for all participants. We have a zero tolerance policy for any form of sexual exploitation, abuse, or harassment or misconduct. If at any point during this session you experience or witness behavior that makes you feel uncomfortable, please know that you can report it confidentially through the following channels. As I mentioned earlier, Fatima as our safeguarding officer, but you can send an email to safeguarding@afhea.org. You can send an email about such an event to safeguarding@afhea.org, or you can contact us, the safeguarding officer, by phone, +233 054 734 7035. +233 054 734 7035. Through anonymous feedback options available via AfHEA safeguarding system, as I mentioned, all concerns will be handled with the utmost confidentiality and in line with our safeguarding policy. Thank you all for helping us maintain a safe and supportive space for dialogue. May I remind you that as part of this webinar, we are actually recording the webinar so that we can be able to make notes about the discussion that will be held here. So please, if you have any, difficulty about the conversation being recorded, of course, you can please contact us with respect to that. So at this point, let me stop here and please go back for us to start the webinar. And I would like to invite the Executive Director of AfHEA, Professor John Atagoba, to please give us some few remarks as we begin this webinar. Prof, you have the floor.
Yes, thank you so much, Danny, and thanks to all participants who've joined. It's a pleasure at AfHEA to have you join this presentation. I see there's a comment in the chat box, excuse me, from one Arome David, that we can't see the presentation slides. The slides are going to be shown soon, so you don't need to worry, Arome. Now, we welcome everyone here to this presentation that will be delivered by our own person, who is also daughter of African soil, Dr. Esther Bikoye. This is according to what Danny just talked about, culmination of assessment that's been done to curate the gaps that we've seen on the continent, focusing specifically on West and Central Africa, where our mandate is to know areas that are neglected or have not received the kind of attention that they should have received in terms of sexual and reproductive health and especially rights. We are grateful to support we've gotten from IDRC, from CIHR, and also from Global Affairs Canada to be able to carry this out. And we have duly acknowledged that from what Danny gave. We want to also highlight that the sexual and reproductive health and rights on the continent is something that has not really been paid significant attention. We've seen poor statistics, especially from the West African region, even as we look at statistics like early childhood marriage, complications that arise from early giving birth to kids at a very young age, including fistula, etc., are things that we have struggled with on the continent. No, some people might want to see my face. I'm happy to share. If you want to see that ugly face, it's okay. So it's a pleasure to open these, and we will be happy to have an engaging session where people can feel free to express themselves. And if you feel hurt in any way, the channels are open for grievances and complaints. So without further ado, I will hand this over to the MC to continue proceedings. And we will be here to listen and also to contribute to shaping the future of sexual and reproductive health rights on the continent, specifically focusing on West and Central Africa, but of course, not limited to that region. Thank you so much. Over to you, Danny.
Thank you so much, John, for those wonderful words. Now, basically, the webinar is going to proceed as follows. We will have a presentation on the, scoping work that AfHEA has done as part of this initiative. We have a presentation by our own Esther, and then after that, we actually will make provision for Q&A. So please get ready as the presentation rules. You can get your questions ready or contributions ready. At a point, once the presentation is completed, we will allow, audiences to ask, questions or make contributions. If you feel, okay to put your questions in the Q&A, kindly do so, and we're happy to, pick them up and answer. So thank you. And at this point, I would like to welcome Dr. Esther to make the presentation. Please, you may want to put your video on, that's all. Thank you. And over.
Hi, everyone. Good day to everyone, wherever you are listening to me from, or hearing me from, or joining us from, either way. It's a pleasure to be here, and I appreciate AfHEA for the opportunity to be a part of this project. So like the introduction and the welcome remarks talked about, I'll be taking us through some areas of sexual and reproductive health rights in West and Central Africa region that has been neglected. And this was done through an evidence-based approach. So I would like for you to follow along as we dive through to see some of the findings that we got through this research activity. So this is an outline of the presentation and our conversation today. We're going to walk through these together, and hopefully to be an interesting time together. So to begin, as we may know, the sexual and reproductive health and rights of every human being is a core part of everyone's rights, and it's very critical when it comes to gender, or when it comes to the health and the overall well-being of any individual, which is a very critical part of the social and the economic development of everyone. So to give a little bit of more, excuse me, please, to give a little bit of context more to the SRHR, which I'll be referring to a lot throughout the duration of this presentation, instead of me having to call sexual and reproductive health and rights, I'll just say SRHR, or SRH for short, as we go along. So just to give a little bit of context, when it comes to sexual reproductive health rights, SRHR, like we've established in the previous slides, is integral to everyone's health, not only the health, but not only the physical health, but also the mental health. And is also core when it comes to measuring progress for universal health coverage. And there are so many benefits to it beyond gender equality. It also empowers people as a whole. And it also helps to advance well-defined, coherent strategies as well. So before we talk about the areas that have been neglected, it's also important for us to be able to appreciate the progress we have made as a region when it comes to West and Central Africa, more specifically. Across this region, over the years, we've been able to record about 34% decline when it comes to maternal mortality for the West Africa area, or West Africa region. For the Central Africa region, they've had over 50% decline when it comes to maternal mortality in the past 25 years. And also, when we look at it in terms of the Millennium Development Goal and the Sustainable Development Goal, they've been improved maternal health towards the core goals for MDG 5 and for SDG 5. Also, it's also important to highlight that nationally, there have been some translation across states and districts for different operational plans when it comes to maternal health. And whether we want to also talk about that, but it's also be key to emphasize that capacity have been built in ensuring that national experts when it comes to antenatal and emergency obstetrics care across the region have also surfaced over the past decades. So our current reality for this region is the fact that there's been so much that has been done when it comes to antenatal care. A lot of activities have been done to mitigate maternal mortality from the front of sepsis, hemorrhage, eclampsia, obstruction. And also there's a whole lot of attention that has been focused, concerted efforts towards the area of family planning, HIV/AIDS, adolescent pregnancy, postpartum care. That doesn't mean that the comprehensive sexual and reproductive health needs to be under these particular areas that we are focused on in the region. So this slide is just for us to be able to see when we're talking about sexual and reproductive health, what does that look like in a comprehensive manner? What does that entail? So it goes beyond just the sexual and sexually transmitted infection and HIV/AIDS. It goes beyond antenatal care. There's so much more there. As we could see from this slide, we have safe abortion services. There are other areas when it comes to, when we talk about intersectionality. So a comprehensive sexual and reproductive health vis-a-vis the area where we have made progress will, when you look at that together, you'll be able to highlight, okay, which area are we lacking? So we have areas we've highlighted as progress. We have our true definition of what a comprehensive sexual and reproductive health should be like, or should look like, or a picture should look like for our region. Then we begin to map out which area are we doing well, which area are we still struggling, or we need to actually increase efforts in that light. So with that being known, that actually drove us as a team to be able to identify what our aims, which actually informed our research question. So I wanted to highlight the areas of neglected areas for SRHR and be able to know what are the populations that have been neglected in this region. And we also wanted to identify the countries, which countries have been carrying out research or activities in this area when it comes to the West and Central African region. So in doing that, we used, we carried out a scoping review, and we used the PRISMA approach and infusing that with the JBI guidance for conducting systematic scoping review, which we registered in the Open Science Framework. And our methodology cuts across the eligibility criteria, having that well defined, and also identifying our information sources, carrying an extensive search in that area. And also I am selecting the evidence based on our eligibility criteria, and of course, abstracting and synthesizing those information that we've gathered. So for this information to be very robust, and for this approach, or for this review to be very systematic in the light, we needed to highlight the criteria when it comes to the population we're interested in. We were interested in population that that's highlighted on the screen. I'm not going to read everything out, but you could actually see some of the population that we haven't been looking at as a country, as a region, rather, not as a country, beyond the country, as a region. In looking at individuals who have been neglected when it comes to sexual and reproductive health rights. And of course, we also needed to narrow it down, as you could tell from everything we've talked about earlier and from the introductory remark, that we focused on when it comes to geographical location, Central and West Africa was our focus. So any studies that was done in Africa, but not in Central and West Africa, were excluded. And then also countries that may include other region, but also had countries from West and Central Africa were excluded. So it was strictly countries or research or activities that were done in Central and West Africa. For inclusion criteria, we also ensured that there were only empirical studies were included, studies that were published in English, and there were no restriction when it comes to the publication here. So for exclusion criteria, we excluded studies that looked at men and women together. We also excluded studies that focused on children less than 10 or adults, young adults older than 19. Studies that also had stakeholders or policymakers, because we believe those will mask out the true or the real results, or mask out some of the findings. Countries that included other parts of Africa, not just strictly West and Central Africa, were also excluded. Of course, abstracts and, like I mentioned earlier, non-English, and studies that were just protocols or book reviews or dissertations, where all of those were excluded as well. Now, for the information source, we looked at this electronic databases, and for I'll talk about it in the coming slide, but those were the electronic databases that we looked at, and the results, or the result that we got for each of the search outputs from those databases is what you have in the numbers. And as you could see from the the schema on the right-hand side of your slide, in total, at the end of the day, we had 94 studies that were included for this review. This is a Prisma flowchart just for us to be able to see how it was done in a systematic approach. And it was so thoroughly done that for every study that was excluded, we categorized them to see which area does it fall. So you have studies that were categorized into HIV/AIDS, some into contraception, those that were on maternal mortality. We categorized all of those studies that were excluded just for it to be very robust and comprehensive at the same time. Covidence was the software that we use for this systematic review, for this Covidence, for this scoping review that was done in a systematic approach. And the title and abstracts were also reviewed. We went on to look at the full text after going through the strict eligibility criteria. And for us to be able to include sources that may not have been captured when we were carrying out our initial search, for every studies that were included, we reviewed their reference list to be able to see if any of the studies met the inclusion criteria that has been highlighted earlier. For the extraction team, we wanted to capture as much information as possible in such a way that if you want to carry out like a data mining, even afterwards, you can go back to the bank, the research bank of this work to be able to extract and tease out more, subsequent research or answers to the research questions you may have. So we cut across all of this extraction team. So beyond the regular title of paper and all of those details that were captured, we're also interested in if each of those studies also capture the current state of those neglected area in the country or region in terms of intervention, or if they also captured gaps when it comes to research or the neglected population or the policies. And also we teased out best practices that were highlighted and future recommendations that were also provided by those authors. To synthesize this evidence, we adopted the Price and Hawkins framework. And this data were synthesized and summarized using the social analysis for reproductive health framework. Now let's go into the fun part, which is the results. And broadly speaking, like I said, 94 studies were included in total, but we categorized those studies into different areas of the sexual and reproductive health areas that have been neglected. You will get to understand that as we go along, but just flow with me at this point. So when we categorize those 94 studies, we have a huge number of those studies, which is about 47 of them, talking about access when it comes to marginalized community and intersectionality. 27 was focused on adolescent health, infertility and subfertility 10, and on to mental health and sexuality. But just to give you a summary of what the areas of those 94 studies really focused on is for us to be able to see from the slide. In terms of the type of studies, quantitatively speaking, we have this, a huge number of the studies were cross-sectional, 39 of them, and the rest quasi-experimental, and as you can see from the slide. So when it comes to qualitative, we also had different categories of studies that looked at these parts or types of qualitative approach in methodology rather for their qualitative studies. And we had 6 other studies that didn't fit into the quantitative or the qualitative cadre or category. 5 of those went through or used the mixed method approach, which include both quantitative and qualitative. Then we have 1 study, which was just an author's perspective. And that study was worth including because the author was a blind person who is a person with a disability and spoke of his own experience based on his rights, which was neglected. So which was why it was included so it doesn't fit into either the mixed method or any of the qualitative and quantitative methods. Okay. When it comes to distribution of the studies, if you recall from the inclusion criteria that I mentioned earlier, we didn't have any restriction regarding publication dates. So we're interested in seeing everything that has been published right from when any of those databases have been capturing data till date. So we found out that the first studies was published in 1999 up until 2024 when the study was done. But you could see that traction, we've been having traction when it comes to this area only in the last couple of years in 2022, where you have 2022 and 2023, we have a huge number of studies across board. But over the years, you could see that the efforts in this region concerning this area of research has been really, really narrow and super small. Also, one part of the aims that we mentioned is we wanted to know the countries that have been working in terms of intervention, in terms of research in this area of SRHR. And in doing that, we're able to capture 13 countries out of the over 20 countries we have in the region, as you could see the slide. But not only were we interested in the countries who have been doing the work, we also wanted to see how much work each of these countries have been doing. So out of the 13 countries, you could see from the slide, Ghana and Nigeria being the first two countries with the highest number of efforts so far. Doesn't mean their efforts is maximal, or doesn't mean the effort so far is adequate. It just shows how much of efforts they've done over the years when it comes to this area. Okay, in terms of the population, based on the studies that were included, we wanted to see based on vis-a-vis the inclusion, the population we highlighted to be included in the study, wanted to see the studies we've included, how much of them captured this area that we have highlighted. So we could see a number of studies focusing on people with disability, women, adolescents. Does that mean that a lot has been done or enough has been done in that area? No. However, I would like us to also focus on the lower part of this chart where we have studies that cover street or road workers, people living in slum, domestic servants. So there's still a lot that needs to be done when it comes to looking at those population, people living on the streets, the internally displaced people in the context of SRHR again. So there's still a lot that needs to be done when it comes to studying this population and their different rights when it comes to us providing comprehensive SRHR in the region. So for those who appreciate maps, this is just to highlight the countries. The country with the darker blue shows where they've done a whole lot of studies. It's also similar to the slide we've already seen earlier, but I just wanted to show this on the map for those who actually appreciate to see this on the map. So in synthesizing the evidence, we've been able to see that these 7 areas have been highlighted as neglected parts for sexual and reproductive health, right, for the region. Infertility and self-fertility, adolescent sexual health, safe abortion services, sexual and gender-based violence, mental health and sexuality, intersectionality and SRH, and prevention and treatment of neglected tropical diseases. So those are the 7 areas that we are identifying or highlighting as areas that needs more work on in the region. So we're going to take each of those. We'll talk about the current, what we have currently for each of them, the evidence, the gaps that we identified, and of course, recommendation for each of the sub-teams. So we're starting off with infertility or subfertility, as some people may use. There's little or no evidence when it comes to this. And literally, from literature, our region, which is the West and Central African region, is considered the infertility belt in sub-Saharan Africa. And the subfertility rate for this region is double the global average. The global average is about 12%. Us is even way double. So and it's in double digits. So currently about 30%. Even though a lot of effort has been done in this area in the aspect of high fertility rates, but the subfertility or the infertility area has been neglected for so long. So there's a lot of focus and drive on contraceptive use, which is great, which is good, but not in negligence of this area. And when we looked at it, only 6 countries had evidence in light of this, like only 6 countries from the studies that we looked at, only 6 countries were highlighted for from the inclusion criteria when it comes to infertility and subfertility. So what's the evidence we have on ground? Currently, only traditional medicine is used as a prevalent means for treatment of infertility, with a prevalence rate of over 80% in a country like Nigeria, where they use traditional medicine for infertility and subfertility. And that's because it's super expensive to be able to obtain this treatment in regular and modernized hospital. And also, we could also tell from the literature that most healthcare practitioners do not consider infertility or subfertility as a life-threatening issue. So therefore, biomedical treatment towards that is not considered a priority. So individual tends to move towards the traditional medicine. However, when the traditional medicine fails, they fall back to the biomedical treatments. And of course, there's no coping strategies for individuals who are going through these problems in terms of sticking treatment, and no research has been done in this light. So some of the gaps that have been identified is we're still yet to define and know some of the causes of infertility. It needs to be explored the more. There's a huge research gap among subgroup population of women who may be experiencing this challenge. And also limiting, we have very limited services when it comes to infertility, and huge positive when it comes to the causes, the psychological impact, and the treatment of infertility. So what's our recommendation? First is the fact that we want the healthcare providers to be able to provide favorable outcome for their patients, to be able to inquire their past history when it comes to traditional medicine, to be able to, and we also recommending that there should be some form of synergy between the healthcare providers and the traditional healers, and also the use of science to be able to carry out research on the use of medicinal plants for treatment in developing new plant-based infertility drugs, and health education when it comes to this area of infertility, of subfertility, and for stakeholders and religious organizations, key stakeholders, to be able to enlighten the populace more on the scientific causes of infertility. The second one we're going to look at, or the second neglected area, is adolescent sexual health. I would like to say here that there's a whole lot that has been done for adolescent sexual health prior to now in the light of HIV/AIDS in that context. But when it comes to key areas like sexual education, which we'll be seeing, there's still a lot to be done. So our current reality for us in the region, about over 60% of the population are less than 25 years old. And from our region, we've had high prevalence of early sexual debuts of about from 15 years and above, and high rates of unprotected sex, which is taking place. Then in some countries, we've recorded as high as over 80% of child bearing age, high marriage amongst individuals of childbearing age, for individuals who are less than 18 in countries like Liberia. Also very important is the societal norms and stigma when it comes to adolescent sexuality. For our region as well, there's limited educational opportunities in having open discussion when it comes to sexual health conversation for adolescents, which in the feedback to the reason why you have high number of sexual violence when it comes to this particular population group. So from this evidence, over 80% of the studies that were included focused on sexual education. However, we have others that focused on the other 20% focused on sexual violence and contraceptive use, which was from the evidence. And we also found from the evidence that the use of digital media in sexual promotion is super rewarding and is a low-hanging fruit that could be used as for policymakers. The use of comprehensive education is also key and critical. However, from the evidence, we were able to gather that there are some subpopulation amongst adolescents that have been neglected, like adolescents who are disabled, adolescents who engage in street hawking, or who are incarcerated or internally displaced. And the huge proportion of these adolescents have never even visited health facility on the basis of SRH. And also when it comes to adolescents as well, we found out that policymakers, stakeholders still believe that withholding information when it comes to sexuality for them will actually prevent them from actually becoming sexually active, which is so not true, because education empowers, education informs. So having those education out there for them will be very critical. And also the lack of social skill is needed for these adolescents, which can only come through education. So the ability for them to be able to say no to unwanted sex or negotiate for safer sex, which is very critical. Then, like I mentioned, of course, some of this subpopulation which have been neglected are susceptible to gender-based violence, making them more fear for discrimination, amongst others. Now, for the gaps that have been identified in this area, there's a huge research gap when it comes to sex education for adolescents, not only to the adolescents, also for the parents or caregivers to be able to have appropriate and adequate understanding to be able to provide those education to the adolescents. Services also when it comes to this subpopulation, like for those who are in the streets or out of the streets adolescents, or school-based adolescents, or out of school adolescents, is also not adequate. We also have exclusion of some subpopulation when it comes to comprehensive sex education. So what's our recommendation? The first recommendation is at the country level, we need to engage more in terms of sex education, in identifying that is a need that needs to be done, and engaging healthcare providers and stakeholders, relevant ministries and commissions to be able to intensify sex education across board. And this should be in tandem with the country's convention. Now, when it comes to school-based, because we have some adolescents who are in school and some who are not in school, for school-based adolescents, it will be key for us to be able to integrate sex education into the curriculum and ensure that there's like a peer-to-peer education that are led by the teachers, but also domiciled in the school, and also strengthening school-based club and ensuring that some of the teachers and the service providers in the school are routinely being engaged when it comes to training, capacity building, for them to be able to serve as a resource when it comes to sexual information seeking. Also, in education, we can't overemphasize it when it comes to adolescent sexual health. Developing appropriate and continuous education across board for the country, and not doing this in isolation of the context, social context of the country is very important. We also ensure that modules should be user-friendly and effective. Then the inclusion of those individuals, people with disability, in the country's sex education program is very critical, which boils down to the last point of when you integrate that, that education, we have that will birth booklets like that are in brailles for others or for individuals with special needs. Now, when it comes to healthcare providers, empowering them to be able to provide and support education to families, and also training them to be able to respond to the health needs of these adolescents, or paying attention to their family history and other details as may be required. The third is safe abortion services. When it comes to safe abortion service, we have, based on the data, over 1.8 million unsafe abortions happen annually in West Africa alone. Only West Africa. And this limited access to safe abortion service is what births the unsafe abortions, unsafe abortions that takes place annually and results in very high complication rates. So we realize for the region, we have the laws and policies when it comes to abortion swinging from very liberalized law for some parts of the region to very stringent laws across other parts of the region. We have countries with very permissive laws and some that are very strict. Then also, when it comes to safe abortion, most of the services, safe abortion services, most of the women lack knowledge of their legal rights when it comes to that. Even in countries where it's liberalized, most of those women do not even know that it's legal or how to go about it. And of course, like you can get as well from other areas of health, there's a huge shortage when it comes to human resource for health in terms of healthcare professionals to be able to provide the services for individuals who require it. So what you find because of the, lack of education, because of the policies swinging by across the two pendulums, we therefore have women who self-manage abortion. They use misoprostol, as we find in most countries. And just legalizing abortion alone is not the solution, but actually being able to take steps towards eliminating unsafe abortion is actually the goal for this particular part that is being highlighted. Then, of course, when it comes to cultural and contextual reasons, the hush-hush general silence when it comes to abortion makes it very difficult for individuals to be able to undertake it, and which results in complications that are poorly managed and criminalization, which actually feeds into all of this. Criminalization of abortion results in, of course, limited availability when it comes to this. Therefore, the gaps identified in this area, there's no documentation when it comes to the decision-making that women go through when they're able to, or when they're about to carry out the self-managed process or service. And like we highlighted, shortage of healthcare providers to be able to carry out the services. For healthcare providers who are available to, they are untrained or inadequately trained to be able to provide the services. And some of the self-administered abortion services are actually not yet registered by some of the countries, and there's little or no research documenting or experiences of women who may have gone through these services for us to be able to learn and from them to inform the policies across our region. So we are recommend that we improve women's education when it comes to this. And in that, you're improving access to safe abortion services and, of course, bridging equity gap. And this, for this particular and as it is for every other area of the neglected SRHR, it requires concerted multi-sectoral strategy, and that involves stakeholders across multiple sectors coming into play and working in synergy to be able to ensure that there's an improvement in this area, and improving access to family planning methods and contraception and research when it comes to this area. So talking on sexual and gender-based violence is the fourth area that has been neglected in this in the region for SRHR, and that's because over 11,000 people report this case in Central Africa as a country alone, Central African Republic as a country alone. And this report is just for 6 months in a year. So we can just have like a picture of how much of a burden it is across other countries in the region. And also education, we could see why it plays its part, because 80% of the women believe that spousal abuse is justified under certain circumstances. They give reason why it's okay to actually experience that. Also, as part of our current reality in the region, some subpopulations are consistently at risk of this. That's adolescents. We also have people with disability, and with individuals who encounter or experience SGBV, those who are disabled are 2 to 5 times more likely to be abused as compared to those who are not disabled. So the frequency also when it comes to accessing services for those who may have been affected is also not available. Then for some other subpopulations that are in this category, like the female sex workers and the migrant female sex workers, actually face worse reality or worse experience when it comes to SGBV. So this is just to highlight some of the subpopulation: adolescents, female sex workers, women with disability, and of course the migrant FSWs are some of the individuals who are more prone to experiencing this. The gaps identified: we have limited research when it comes to this across diverse population. There's also need to also explore other population with disability, not only women, and also migrant sex workers. They are a very minor population, but due to lack of legal framework and policies to protect them, it even makes them more prone to SGBV. And of course, there's positivity when it comes to barriers in seeking help for those who may have been affected by SGBV. So our recommendation stems from those who are most vulnerable to it, beginning with the female sex workers, having to be able to have a structural approach to be able to end violence when it comes to them. Like I said, it's a multi-sectoral approach. So having a partnership with these individuals and the police and lawmakers and law enforcement agencies is also key, and improving services, health services for them to be able to address stigma and discrimination for this population group. Then for women with disability, it's also important to be able to design systems, interventional systems that will help to address their various needs, and also be able to increase awareness on the rights and where to seek support services when they require. Training personnel and professionals when it comes to violence support is also key, and ensuring that there are efforts put together to be able to promote program and policy that protect them. For migrant female sex workers, it's key for us to ensure that, or know at the back of our mind, that we are committed to providing health services to everyone, irrespective of their population, irrespective of their profession, or irrespective of their status. So embarking on a process where we decriminalize this work for them and ensuring that it's a safe space for them is key. So for the fifth is the mental health and sexuality. For this particular one, poor mental health has been associated with risky behavior, such as having multiple sexual partners. And it's also been known from research that negative impact is associated with SRH issues and mental health outcome. However, there's also huge gap in evidence when it comes to mental health and sexuality across diverse population. There's little or no data when it comes to this in terms of identifying this in the area, and also checking for the prevalence of sexual function and the quality of life. Then when it comes to the prevalence data for sexual function with people with disability, there's actually none in existence for our area. For this area of neglected SRHR, only one study focused on this amongst all the included study, and the study was done in Ghana. and they explore the prevalence of sexual dysfunction and its impact regards in tandem with the quality of life amongst people with disability. So therefore, it's important for more work to be done in this area, and also to the need for education and awareness to be able to address the emotional and sexual need of individuals with disability and even those without disability, in ensuring that their mental health and sexuality is in place. We're almost there. For intersectionality and SRH, for this, we try to explore the multifaceted challenge that individuals may identify that as at an intersection, or create challenge for them in experiencing or assessing SRH services. So we have ethnicity as one of it. We have disability, their class, religion, sexuality as barriers that was also identified. Then unique barriers that were faced by some of these individuals cut across rural populace, individuals who are domestic servants, internally displaced individuals, street hawkers, beggars. Those were individuals from this marginalized that identified some of those barriers and challenges that I mentioned earlier. So what's the evidence in this area? We could actually tell that individuals who are with disability face worse health outcome, care assets, and also, of course, it spirals into the health outcome for these individuals. And adolescents with disability even face additional challenge when it comes to that. Recall, we've already identified the fact that adolescents already face challenge in accessing SRH. Now, adolescents with disability, in fact, face that challenge in two folds, or in double layer, if I may put it that way. Then minority ethnic groups in any region always suffer more discrimination as compared to those who are the majority, and of course, experience abuse upon entry into the healthcare system. The gaps we identified is the fact that female sex workers are often more marginalized, which we've identified and highlighted earlier. Women with disability face stigma constantly, and there's also lack of training for the healthcare staff for them to be able to provide and meet the needs of these individuals when they come. Ethnic disparity, and of course, the lack of comprehensive education for sexual aid services across the diverse gender people. Now, for the future, we are recommending that not only should program focus on the challenges that focus on challenging harmful societal norms, but also areas that perpetuate violence. We're also interested in or seeing policies and intervention that are channeled towards adolescents, people with disability, and the intersection of adolescence, disability, and gender as well. Being able to review all the existing curricula that we have in country or in the region on SRH education and see where there are limitations for individuals who have not been included in the SRH education, and also exploring the limitation when it comes to the current Disability Act that we have in our country. Most of the countries, when we check their website, have a Disability Act, but is it comprehensive enough? Is it translating into intervention and day-to-day activities in the country? Is a question that's birth, and we could see from this research that there's still a gap in that area. And of course, integrating education to the specific needs of this population to be able to normalize diverse sexuality and genders, and of course, bringing to bear the fact that we have subpopulations that also needed to be included in our comprehensive SRH. And the last is the prevention and treatment of NTDs, which are the neglected tropical disease. There's so many neglected tropical disease, but the one that we're focusing on for this study, which our inclusion criteria captured, was the female genital mutilation, FGM. It's known established evidence that's a violation of human rights. And based on prediction, it's been predicted that about 68 million girls will still undergo FGM by 2030. And so far, looking backwards in time, over 200 million globally have actually undergone that process. And our research found that gaps have been identified in being able to understand the influences when it comes to decision-making around this NTD. And there still needs to be enforcement. There's currently an anti-FGM laws across our region, but there needs to be enforcement of these laws in order to ensure that there's no inconsistency when it comes to the policy and the law, and ensuring that cultural norms is actually continue to promote the practice. We recommend that education for girls and the female community addresses the law that supports the anti-FGM and should be targeted towards women who are married, those who are older with less education, focusing on change when it comes to knowledge, attitude, and behavior, and ensuring that it's a very holistic approach with a strong political support, and more research needs to be done on other entities in the area of SRH. In conclusion, I cannot overemphasize the fact that there's an urgent need to develop comprehensive intervention to address this area of SRH in our region. And we can't do this just by ourselves alone. When I mean ourselves, just one individual stakeholder. We required multifaceted or multi-concerted efforts across various key stakeholders in the region, country leaders, policymakers, lawmakers across board, to be able to implement this context-specific and culturally sensitive prevention policy to be able to protect the reproductive rights of the populace, and improving education across this different population about SRH. And they need to be able to conduct more research. Of course, we would not be able to overemphasize that. There's need for us to be able to implement a standard in place to care for the different population group like we have highlighted. At this point, I would like to acknowledge IDRC so far for their support for this project, CIHR and the Global Affairs Canada for their support. And I would also like to thank the AfHEA team and the research team for their support. Thank you. At this point, we'd like to take questions. Over to you, Daniel.
Thank you so much, Esther. Fantastic presentation. Yeah, maybe at this point, I already see some questions in the Q&A session. But I would like to invite at this point questions from the audience. So if you are, you have a question or a contribution to make, kindly raise your hands, and then we'll identify you and give you the right to speak, and then you can ask your question. Please, in the interest of time, kindly keep straight to your question and be as brief as possible, so that as many people as possible can ask questions. Thank you. Do we have questions? Let me check. Anyway, in the meantime, you may want to take the question from one of the panelists, Madam Nafi. The question is, do you have any idea of how much literature was excluded because they were not in English? Esther, any idea of how much literature has been excluded because of language, especially those not in English? Thanks.
Thank you so much, Catherine. I think Catherine asked the question. Thank you so much, Catherine, for that question. So, I'm sorry, just a moment. I hear some background noise. Okay. So, to be honest, a huge number of the literature that we found were in English. It was just a handful that were in French, and by the time we sorted out the ones that were in French, as based from the abstract, some of them had their abstracts written in English and French. There were just a few, which were about, I think, based on the literature, about 14 of them that were in French that were not included. So if we look at it based on the huge number of studies that we're looking at, we didn't think that would actually swing our outputs or our results in any direction that may not have been included. So it wasn't a lot. If it was a whole huge number, it definitely would have been something would have considered. That doesn't mean it's not a limitation to the study. Not including French is a limitation to this project, but it wasn't a huge number that we think would have impacted the results. I hope that answers the question, Catherine.
I hope so. Thank you. In the meantime, if Nafi is here and want to expand on it, you are welcome to do that. Would like to take more questions from the audience, please. Kindly raise your hand by using the raise hand menu, and then we'll identify you and give you the right to speak. You can also put your questions in the chat box as well. Maybe in the meantime, I can ask my question. I have a question. I hope I'm allowed to ask. So,
Yes, you're allowed to ask
my
them.
question is actually, I have the opportunity to read through, the so aspects of the report, the work that you've done. My question is, I see, one of the key issues that you highlighted is infertility and self-fertility. I know this is actually perhaps in the context of Africa, or maybe let me limit it to West and Central Africa. I see a lot of this really don't really come up. It doesn't really come up anyway. Even though it may be bundled into the bigger picture of family planning, it looks like it's quite a silent thing, but I see a lot of it, highlighted in your work. How important is the issue of infertility, an SRH challenge in Africa? Can you explain more on this?
Yeah, thank you so much for that question, Danny. So while there's so much efforts regarding family planning is when it comes to individuals who in our context having, huge number of children and not being able to take care of them and, resulting in women, reducing maternal mortality and all of that, or rather increasing the prevalence of maternal mortality. But speaking of that, in one angle, is actually turning a blind side or a blind eye to the other aspect of individuals who require to actually have children of their own and unable to. So therefore, we've kind of not been able to address over the years the issue of infertility and subfertility. We focus so much on the area of fertility, and with that umbrella thinking, we are addressing infertility and subfertility. So it's a huge challenge. And like I mentioned, the West and Central Africa region is actually referred to as the infertility belt of the sub-Saharan Africa. That's telling you that we have a huge prevalence of women who are actually faced with that challenge. But there's been so much efforts, strategies, or policies in the light of fertility issues, or in terms of contraception, in terms of ensuring that women actually puts to check the number of children they're having per time and all of that, neglecting the individuals who are experiencing that challenge. So it's a major issue I would like to say, and not just in terms of the prevalence, women who are also going through it, how do they navigate those phases and seasons is also important. What are their health-seeking behavior? What are some of the mental or emotional health challenge they may be experiencing? And some of the things that we need to actually carry out as well in research to be able to help with policy and inform our decision when it comes to those population. I hope that answers the question.
Thank you so much. Yeah, that's quite good. I see some more questions in the chat box. Maybe I should go through some of them, and then we can see how best to, address them. One question from a participant, Snate Besha. The question goes like this. Many adolescents, especially girls, face legal, financial, and social barriers to contraception and reproductive health services. The question is, what strategies are in place to ensure adolescent-friendly services? And how can countries address stigma and parental consent barriers?
Thanks so much, Senet, for that question. So the first is strategies to ensure adolescent-friendly services. Adolescent-friendly service, I like to say here, it shouldn't just be based in the context of healthcare facilities. So when you say adolescent-friendly services, we tend to look more into the health facilities to say, okay, how, or to try to create a means by which individuals who are adolescent come into the facility. They have an area, or they have a section in the healthcare, in the hospital or in the healthcare delivery section where they can access care. It goes beyond that. Actually, adolescent-friendly services begin from the community. Do we have an area in the community where adolescents can come together, spend time together? Do we have activities, being provided for adolescents in the area? Is it monthly, quarterly, or bi-monthly, for them to just hang out, spend time together, in that way, and through that means, you begin to engage them. Is a means of education, is a means of making them to be part of the community, and also making them see themselves as stakeholders and beneficiaries of this. Through that, you begin to talk to them when it comes to health, if they require health services. Through that, you can actually talk to them when it comes to social norms. Through that, you're actually engaging them and also collaborating with them in actually making it a more robust community to engage them. So engagement for these individuals should not just be focused in the health facility or in the hospital. Over the years, we've focused so much in adolescent-friendly services to be in the healthcare facility. So it begins from the community. Then when we talk about the community, we need to narrow it down, take it 4 or 5 steps back. It begins actually from the home, which is why I would like to address your question when it talks about countries addressing stigma and parental consent barrier. So when it comes to educating the parents to be able to, for them to know that your adolescent may not be able to tell you everything. It's okay for them to be able to open up to a healthcare provider. It's okay for them to tell you, I would like to speak to a doctor, and you don't need to know what they need to speak to the doctor for first. Say, okay, do you need to see the doctor? I can't take you there. But rather, the parental barrier or the consent requires that the parent needs to first know, which is a first barrier, which most adolescents will actually just shoulder or, not discuss, or rather just remain silent over it. Or when it comes to consent, maybe in school, they're required to take a field trip, or they probably need to just go to the hospital for regular checks. They also require parental consent, or they require parents to be there. So those are some of those education that we need to talk to the parents from the parental front or caregivers front with, to let them know that if you do not feel safe for your adolescent to talk to anyone outside, or you do not feel safe for them to just go by themselves, it's okay for you to take them there. But it's also okay. It's okay for you not to be there when they're having the conversation with the healthcare provider. Which I would also say it boils a whole lot to trust, which is a soft challenge, I would say. If the parents trust the healthcare system enough, the healthcare provider enough, they should be able to trust it to know that their adolescents will be in safe hands when it comes to that. So the stigma and for parental consent is a huge one, but it has to do a lot with educating the parents and the caregivers a lot for our context and our region.
Thank you.
I hope that answers the question.
Yeah, thank you so much. Yes, there are still a lot more questions coming up. This one we may have to pay a little more attention because it's a very long one. So the question is from Angela Ruwagu. I hope I got your name right. So the question goes, I noticed that males were not included in the survey's inclusion criteria. Could you please clarify why? As you mentioned, SRH is a fundamental human right for everyone, men included. In our context, men's SRH needs are often even more neglected, and in some cases, almost non-existent. So the long and short of this question is why, if you could clarify why, men were excluded, and then the fact that men's, it's often observed that when SRH needs of men are often catered for, all things being equal, outcomes for females improve as well. So why will you exclude that in your work? So if you can clarify that, thanks.
Oh, that's a great question, Angela. That's fantastic. And yes, you're right. Men seems to be a whole lot neglected in the picture of SRHR. And so because we can't do everything in one study, we can't cover all of the populations that are key in one study. We try to focus on the women population, I like to say, but not just women. If you take notes, with the subpopulation in women. So that's why we focused a lot with people with disability. We focused a lot of like street workers. Street workers, of course, includes both sexes. Internally displaced individuals includes both sexes, but we just did not look at male on its own. So, but all the other subpopulations that were included have both sexes because they were not just specific to women. Internally displaced individuals, who again, the adolescents, of course, include both sexes. People with disability also include both sexes. Like I mentioned, one of the authors that was included based on the perspective he wrote was actually a man who was writing his perspective as his experience as someone who was blind, which is a person with disability. So they were included, but we just did not look at men on its own because it was going to make it too much for this one study. So yes, you're right that men are usually excluded when it comes to SRHR, which is in terms of in a holistic or in a more overview perspective. As a future recommendation is more studies needs to be done looking at just men or focusing on the subpopulation when it comes to men. So, but for this particular study, we focus on women and of course other subpopulation that includes women and men as well. Thank you for that question, Angela.
So thanks so much, Esther. Wonderful work there. Maybe we take some couple more, and then if somebody wants to speak, we can just allow 1 or 2 people to speak, and then we wrap it up. Otherwise, just take this question, and we'll see how we can wrap things up. Could you please expand a bit more on the link between SRH and the neglected tropical disease that you mentioned? That's
the link between, so okay, yeah, so under some of the SRHR, some of the areas that have been neglected is the neglected tropical disease, and one of those is the FGM. We have FGM. We also have the female genital schistosomiasis. There's so many diseases out there, but we focused on the FGM because of the huge population that are being affected, and based on the prediction over the years of the number of women or females that will actually go through that process. So that's why we try to also add it. So when it comes to SRHR, while we are looking at it, most times it's not disease specific in the context when it comes to the rights, but we cannot take away disease or the tropical diseases when it comes to the right as well. So individuals who are faced with that challenge or who may come down with that challenge are also not excluded, as it were. So that's why it was included as part of the area of reproductive health. Based on literature, it seemed like, to be honest, before we started this work, it didn't seem to me like an issue or a challenge. For me, it felt like a battle that we've already fought and won in the region is a victory, but it's still a major challenge actually from the literature. And we can see it's the research, it's what is shown as part of the areas that actually still need a lot of work in the area. So we have the policies, but those policies are actually not translating essentially to the grassroots in that intervention. We still have women who are uneducated who are still doing that for their female. So it's categorized as a neglected tropical disease for under the SRHR scope. So that's the link between SRHR and the NTD.
Thank you so much. Does anybody wants to come in, with some voice contribution to this discussion? Otherwise, we'll pick the last question and we can wrap it up. If you want to speak, please kindly raise your hand and we'll identify you as such. I'm not seeing any hands. Okay. So maybe the last question. So you mentioned, and the question is from Liana Davis. You mentioned legal legislation and policy findings in relation to abortion in particular. Was there much research on the political economic process of changes in policy, positive or negative, in relation to abortion or other SRH areas? Maybe I should take it again you are fine? Great.
Eliana, that's a great question, because as part of what we did for this work, which I didn't have time to also share here, is the fact that we went through each of the governments, each of these countries in the region. We went through all of their websites, their Ministry of Health websites, and other ministries, be Ministry of Women Affairs, Ministry of like all of those ministries that are affiliated or have work that they do as well with health. We wanted to see what policies they have in place. We were even interested in having their health plan. like the health strategic plan for those countries. In some of these countries, we found out that they didn't have the latest or the most recent health strategic plan. For one of the countries that I might not need to mention was 2015, but we also found some countries that have health strategic plan up until 2035, up until 2020, 2025, some up until 2030, some 2035. They had health strategic plan that is, gone 5 years forward in time. However, when we looked at the details of those health strategic plan, most of these areas that we've talked about are missing. There were no areas, for some of those, we didn't have area when it comes to safe abortion, but those safe abortion care in regards to your question. But the area we mentioned earlier, which we have made remarkable progress on, is still the area they are still focusing on as a policy in the country. For one of the countries, they included adolescents. We saw that they've actually included adolescent health. We could actually see the changes in the policy. They had one up until 2020. When they were updating it, we saw that they actually included adolescent health in their policy. Now, that is in terms of documentation, in the policy, black and white. Now, in implementation, would that translate is another question we might need to ask. So if it's not there, that means they may not do it. If it's there, are they actually doing it? Are they implementing it? Do they have interventions in place that would speak to those policies is another question. So, but sad to say that for most of the documents that we reviewed as our gray literature, based on your question, most of them did not include the abortion services. Now, when it comes to changing the policy, we have experiences from other countries or policies or documents from other countries that actually changed and updated their policies. And of course, lessons learned in actually carrying out those interventions, which we can actually gain from or learn from, but they are not within the scope of or within our geographical location for the study, within the West and Central Africa region. Yeah. So sadly to say, not much research in that area. There's still paucity of research when it comes to the political and economic process for that.
Thank you so much. I think you deserve a round of applause. Yeah, so thanks so much for taking the pain to do this detailed work and put the information out there to the public. It is now up to us to pick it up. All the gaps have been identified, and it's up to us as individuals, within our society, within our organizations, to pick these things up and try to amplify the voice that has been, the findings that have been shared here, and make things happen within our societies. We can all work together to, address SRH in our own way. It doesn't have to be big. It can always come from a small angle, and they are the little things that will actually, they say little drops of water makes a mighty ocean. So I will encourage all of us to pick these things up and try to amplify this in our various ways, communities. But before I say bring this to a close, I would like to check with John if you have some few words to share, from this presentation. John?
Yes, thank you so much, Danny. Also to congratulate Esther for that wonderful presentation, as always. Known Esther for quite a long while, so it's good to see that you're on that trajectory. I also want to thank those who have made time to join us, especially not putting people on the spot, but I know the UK FCDO is also well represented here, and I'm very sure that many of the activities we're doing here align well with the FCDO as well. So, Elaine, thank you so much for joining, and also to thank our funders, especially IDRC, CIHR, Global Affairs Canada, and of course the Government of Canada, broadly speaking, for funding the work we do. Yeah, hand this back over to you, Danny. Hi, Danny.
Thanks so much, John. Yeah, Let me also use this opportunity to inform you all that this is work in progress. And that this project, we're actually working with, a lot of other partner organizations, in West and Central Africa. We have projects, in Ghana, in Burkina Faso, in Senegal, and in Nigeria. So let me use this opportunity to inform you that more on this shall be coming with our partners. We'll, at a point when new findings from our work comes up, we would like to collaborate with you to share these findings so that we can all pick these things up in our various organizations and communities and try to, as I said earlier, push in our own way to address these challenges in our society. And so kindly look out for more on this in the near future, maybe in the next 2, 3, 4 months. You will hear from us again in terms of sexual and reproductive health, especially working to address the neglected areas and ensuring that underserved communities and populations are also catered for, and together we can all work to achieve UAC by 2030. Thank you so much, everyone, for coming, and hope to see you in the next few months. Bye, everyone.